analytics teams and ask for data. They put you on a kind of there is a ticket. I don't know if anybody has used it, but it takes a long time. It could take up to months before you figure out what's going on. And then it's an iterative process. You go in, you find variables, you look at it, then you realize you need more data or more variables. You have to slice the data one way or another. So it is like a lot of back and forth, and we believe that AI has that opportunity where not only it can absorb a lot of data and process results quickly, but it also can find patterns on its own rather than us creating a hypothesis and asking the questions and then finding out what we need more. So I think from a quality and process improvement standpoint, there is like massive opportunity here when it comes to readmissions, length of stay, and hospital-acquired conditions. Those are the biggest challenges where we spend a lot of money and we don't get reimbursed for those things. So I think like it is easier to put some value proposition there and an ROI for innovators to come in and really hit the ground running. Secondly, it is because of the workforce issues with the physicians. There's like a shortage of physicians, and then the healthcare workforce, they're not finding value in what they do or how they get reimbursed. So there is a shortage and the cost is going much, much higher. So all these assistive and augmentation technologies that we have, for example, ambient listening, we have this company, First History, that gets the patient's data in front of you before you get into the exam room with the patient. So you have that one whole person view of the patient, and you can engage with the patient directly and solve their problem in a very short amount of time and address everything in patient's own words. And last but not the least, I think like where we are using software or algorithms as a medical device, where they're solving clinical questions and answers, there's a clear ROI on that. So those are the three main areas that we are looking at right now.
Got it. So if I were to summarize, the theme is anything that has a very clear ROI to the health system through process improvement or addressing specific things where you're losing money. If you can prevent the loss of money, you can show an ROI. It's a no-brainer to adopt it.
Absolutely. I think that impact and value is for the stakeholders or for the patients, that's going to be important. So I think talking about the same, like from an innovator's perspective, when you come into a system or when you think about creating a solution, how do you think about engaging with all systems are different, like even large systems, different hospitals in a system are different workflows, academic, non-academic, community. It's a hodgepodge of a lot of different operations and cultures. So how do you adapt or align with those workflows and operational quirks?
Yeah, absolutely. So at Accurkardia, the approach that we've taken with the technologies that we've developed is to make them as transparent as possible to the institutions so that they may not even know that they're benefiting from them. So for instance, we've developed a platform to automate the interpretation of cardiac monitoring recordings, and they'll, so what the hospital will experience is a higher quality report, faster turnaround time, but that it's essentially the algorithms are baked into tools that the technologists are already using, and so there's no change to their day-to-day work. It's just that it's becoming more efficient. So that was one of our first, as you were mentioning, any workflow improvement or productivity enhancements that don't require a change in the day-to-day work, flow, not having to learn a new tool, things like that. If you can implement something that makes people more efficient, it'll be adopted more quickly. So that's one way. The other one is trying to sell an enterprise software solution into a hospital system is an incredibly challenging thing. And so our approach has been to avoid trying to develop yet another platform because the hospitals are just inundated with the IT requirements of implementing these systems. So rather than build a platform for algorithms that we intend to implement in a healthcare system, we want to leverage or take advantage of the platforms that are already there. So this could be the EMR, it could be the ECG management platform. So our company builds ECG AI algorithms. We see the existence of existing platforms like a GE Muse or a Philips IntelliSpace as a natural platform that already exists in the account, that it's already being used, but we add an application to it. And so that's part, that way you're not adding another box or another software layer, we're adding functionality and making it easier to adopt.
And how easy it is for you to come into a system and adapt to, for example, if you have a Philips or a GE system, to work with them or work with our EMR system, because we already have this multimodal thing from Philips going into the Epic in a PDF format, and then nobody can read that format. So how do you guys tackle that?
Yeah, we have to, first off, we work directly with our strategic partners to integrate our algorithms. So, we would basically make this essentially a part of their platform, and that's what we've been aiming for, so that it's a seamless interaction. It feels one and the same, or just exactly part of the platform. So I think so long as you can make it seamless to adopt, and it's part of the natural way of working for the hospital system, it'll be adopted more easily. As soon as you start imposing a process change, or you're adding workload, or there's a new responsibility, that's when it becomes harder to drive the change management, and we want to avoid that.
Yeah, I think like if you can keep compliance and IT folks less twitchy,
yeah,
they'll be better off. So I think like another thing that for hospital leaders to know, when you read the data, you read the research, it turns out that some of the AI models were trained on some specialized data sets or very focused data sets. It solves a problem, it does the work, but then how do you scale from there in terms of adapting to other needs or extending it into other areas of the same domain?
Great question. It all comes down to validation. So you cannot just validate on one data set. You really have to get a diverse set of data from different types of institutions, different types of patients. Make sure that you're testing with data that has the full range of potential comorbidities that could confound your algorithm. So it really comes down to scale and numbers. And one of the things that we've done as an organization is partnered with the AHA AI Assessment Lab to validate some of our algorithms. And the data available through that platform is remarkable. We just presented an abstract yesterday on hyperkalemia model, and we were able to get 184,000 patients through the AI Assessment Lab, and there's more and more health systems adding on to that robust database. So I think just by the sheer scale and size of large validation data sets that are coming available, you can solve that problem of applicability and generalizability.
So if I understand correctly, when you develop a model using the AHA validated data set, and then you go into different systems, so 180,000, and then, as hospitals join your program, your AI is going to get more like smarter, more efficient by continuous learning, or it's just using the same data set?
So what we did specifically in our case is we initially trained on the Mayo Clinic platform, which has a fairly decent geographic distribution. And then we did a subsequent validation on the AI Assessment Lab, which has multiple hospital systems in it, including the Sharp Health System in Southern California. It has Texas Health Resources, which is North Texas, and then you have Sanford, which is the Dakotas, and they're adding more. So that added, quite a bit more patients, as well as the geographic and institution type diversity. So, by virtue of the sheer numbers of patients that we were validating this on, and the variety in the data set, we got a fairly good confidence that this is generally applicable, and that we were able to reproduce the results that we had at Mayo. I think some of the failures that early models had was that they would develop the model on a data set, and then in the same institution they'd partition the data set and validate it there. But there's unique things about that system that may make the model only applicable in that context. So it's really important to do external validations to make sure that it's working more broadly. And frankly, the FDA is now requiring it.
That's very helpful. So from a health system perspective, what do you want a system leader or strategic team to know to trust that this is the solution and that's going to be around for a year or two, and not we have to be looking for something else?
So one of the things that we find critical, we think will be critical, and tell me if you agree, is if there is, for our novel technologies, if there's a reimbursement associated. And so I think that will help dramatically, because it not only is it a potential opportunity for revenue generation for the account or for the hospital system, but if you're able to generate enough evidence to convince CMS to provide you a reimbursement, there's likely some value there. And so that's kind of the threshold that we're setting for ourselves, is to seek that reimbursement for the algorithms that we develop.
That's very helpful. As far as there is a reimbursement path is easier.
It's easier, yeah. When it comes to the workflow enhancement, you know, it's more obvious that we're providing an efficiency gain, and it's more a matter of the institution trying the software and seeing the, you know, doing a pilot and seeing the benefit, and then they adopt. But in the case of our novel algorithms, I think it's key that we pursue a reimbursement, and then there is a financial incentive to adopt, and then additionally we've gone through the evidence development to show that there's clinical utility.
I think like in a previous session, Effie mentioned that they signed a contract with the company 2 years later. They have not used it, and that's not uncommon. And in my personal experience, we worked with the company, and it was not even a matter of a year. While we were having those conversations, we were kind of piloting a use case with them. And in the meantime, there were 2 companies that came out with the bundled product. We didn't have to do use case. There's a bundled product. There is proof of success and revenue model attached with it. And then I'm sure like you guys are hearing this, like a lot of systems are now contemplating, should we buy or build? So everybody is trying to hire, you know, experts in this area and trying to build their own. So a year later, we didn't even have a solution. So what would you say to leaders, like what's the right approach from your perspective, because you guys know a lot more about AI, algorithm, technology, and where should we go and we shouldn't go?
That's a great question. It's uncharted territory. I think I'm surprised anyone would try to build things on their own. Usually there, you know, it usually takes a high degree of domain expertise or specific focus, and I would think that it would generally be challenging for hospital systems to try and develop on their own. Now, you know, there are some of these luminary accounts, Mayo Clinic. They've built their own platforms. They have their own researchers. They've spun out their own companies. I think, you know, maybe if you have enough of the infrastructure in place to build at that scale, then you could pursue it. But for smaller smaller hospital systems, I think it'd be challenging to replicate what Mayo's done with the platform, for instance.
So I think in the last 20 seconds, like my perspective is that, again, our previous presenters talked about get in fast and also be prepared to get out fast.
Yeah.
Because the technology is going to, and people ask me about what do you think what's going to happen in 5 years, and I can't tell them what's going to happen in 2 years because things are evolving so fast. Thank you.
It's a pleasure. Thank you.
You too.